We're going to go ahead and get started. A few more people, I'm sure, will be coming in. But it's my pleasure to introduce the afternoon, which we're calling IRLM afternoon, Implementation Research Logic Model afternoon. And here to explain the IRLM model is J.D. Smith. Thank you.
Yeah, so like the other presenters, I really want to express my gratitude for the invitation to be here and for the fantastic logistical support. This thing will go completely smoothly because of them, not because of me, I promise. I forgot to ask if there's a clicker and or pointer. Okay, I don't need it quite yet, but if you can get it. Is it this thing? Does it have a pointer on it too? Okay, so I'll just like literally point. I don't think I am. You're testing my technological skills. Okay. Okay. It's not actually on this.
No. So you'll end up pointing here. So if you go up into this window,
okay.
Click on the pen here.
The pen. Then I can actually do stuff.
You can select laser pointer.
Oh.
And then as you're going around and
okay,
turns into a little red
love
dot that you can see up there.
Okay, I learned something. Perfect. Okay, so yeah, IRLM afternoon. The IRLM is the implementation research logic model. I'm going to talk a little bit about how to apply it in community engaged studies. But to be honest, like this is really, it was developed and is intentionally broad, content agnostic, and agnostic to context as well. So it doesn't matter if you're using this in schools, if you're using it in healthcare systems, it is applicable. So I love this quote. I lead off every IRLM talk with this quote from George E.P. Box, which really answers the question of maybe do we actually even need another model? There's so many theories, models, and frameworks in implementation science. Usually I do this talk on the tail end of having introduced people to like 18 new acronyms on determinant frameworks, process models, evaluation frameworks, and a little bit of theory, which I'm not very good at. So I have like 2 slides on theory, but that's okay. But basically, I want you to just kind of keep in mind, especially if you've been through implementation science talks before or have applied different implementation models, that essentially all models are wrong, but some are still useful. So even though you're probably going to see problems or things like I would have done this differently, or how does the IRLM do this? Maybe it's not supposed to, but hopefully it's still useful. Okay, so here's my little argument about how or why, I guess, a logic model that is specific to implementation research is needed. And I'm going to start with a little story. Anybody here ever submitted a grant to the CDC or the US Department of Agriculture where they required a logic model? Anybody, was that an implementation study? Okay, no. So my colleague and I, back-to-back grants, CDC, USDA, they required a logic model. So of course, being good little grantees, we created a logic model. We got both of them funded. We went back to the logic model after the grant was funded, and both of us who were both implementation researchers said, this is completely unhelpful for implementation research. I don't think it was helpful in putting the grant together or helping us think better about things at all, to be totally honest. It was a box we had to check to get the grant submitted. So that was actually what planted the seed for me, that potentially a logic model that is specific to implementation research is actually potentially needed or could be viewed as useful. So what was the purpose of this and what is it supposed to do? So this is really intended to integrate all of the necessary conceptual elements of implementation research, which in most large studies is going to involve multiple models, frameworks, or theories. And this has been, or at least was, a really significant challenge. So if you have CBER as a determinants framework, help you understand context, facilitators, barriers, how does that line up with implementation strategy taxonomies? And how does it line up with Proctor's implementation outcome framework, with REAIM? How do all those things go together? Large grants typically would have 2, 3, 4 models and frameworks. And how do you put those together in a sensical way? You can do it, of course, but it's often very difficult, and especially for new learners of implementation research, to actually do that in a good way. It was also intended to increase or improve the transparency, rigor, openness, specification and reproducibility of implementation research. And Danny talked a little bit about the need for protocolization or manualization of a lot of the things we do. We still are plagued with issues with all 5 of these, but hopefully we're getting better. Okay, we all know what rigor is. Okay, so I do think that this second bullet point is really important, is to improve the specification of the phenomena in implementation research, which really helps us understand how implement strategies actually work, for whom, and under what determinant conditions. So an implementation strategy that works in the hospital down the street might not work right here because the context is different. Okay, the clinical problem is the same, but we're trying to do it within a different culture, a different climate, different contextual barriers, all sorts of different things happening. And the implementation research logic model, similar to all logic models, is intended to help us actually put on paper in appropriate form testable ways of explaining those phenomena. And the logic model itself helps us to specify the relationship among variables, which enables prediction of our outcomes and can actually translate into testing for mechanisms, mediation, moderation, et cetera. Okay, so some terminology. I'm actually going to skip a little bit of this, or at least be really quick with this. So in implementation research, officially, according to NIH, we are trying to evaluate the use of implementation strategies. That's what implementation research is in a nutshell. Amy talked already about the thing is the innovation we are trying to implement. Things can be lots of different things. We often talk about interventions, programs, practices, treatments. You can try to implement a tool that's related to improving health outcomes. We do guideline implementation. New pills come around all the time that we need to implement. So this is a fairly broad bucket of things. And then our implementation strategies, Danny gave us a really good example of that. It's really what we do to help support people and places do the thing. And then we talk a little bit about the recipients. These are often called the beneficiaries or the targets sometimes of implementation strategies, and the thing. Okay, so I typically personally anyway, will refer the word recipient to the innovation. Okay, so this is the people I'm trying to actually get the intervention to. And we also sometimes, and Danny talked about this, was we do have targets of our implementation strategies, but they're typically clinicians, clinical teams, clinical processes, hospital systems. I mean, they're the higher order stuff. Okay, so just to kind of go back into everyone's favorite lecture on traditional logic models, and how does this align with implementation research? I did a presentation to the CDC in 2018, 19, even before the paper was published, on the implementation research logic model. And because there was going to be a whole bunch of CDC professional evaluators in the room, I actually went through the process of kind of saying, how does this align with what you already know? And how is it different? What does it do that's a different function or different, actually different components? So in the traditional logic model, which everyone probably has seen before, it's called a pipeline logic model. That really, says that there are certain inputs that we have that lead to different activities that we're going to do in our program, short-term outputs, as well as short-term outcomes, intermediate and long-term outcomes. And then there's a whole bunch of different potential moderators of these relationships and things that are going to make us either go through this more smoothly or are going to hinder it. How do we layer implementation research on top of this? So resources really are kind of the things that are needed, the capacity, the people, the technological capacity, all those different things that would help us actually do that. The activities are really implementation strategies for the most part. In a traditional logic model, it's not limited to implementation strategies, but if we're applying this logic model to implementation science, really the activities are strategies. Our outputs. So the outputs is a little interesting because typically, and I think Danny showed this well too, I usually show the implementation outcome framework from Proctor that says that the short-term outcomes are sort of the mechanistic things that change as a function of the strategy. The intermediate outcome is typically an implementation outcome. So to achieve adoption, there are certain processes that we're trying to enact in the short-term outcomes or the mechanisms from a certain strategy. And then our long-term outcome is typically going to be full-scale implementation as well as population or public health benefit from the intervention itself, okay? That's how that kind of layers on. And then the moderators, they actually say contextual factors that are out of control of the program. I argue a little bit that some of the contextual factors are not out of the control of implementation researchers, we often do change contextual factors to help facilitate implementation. But it's very similar to saying this is all the things in the context that are going to potentially either help or hinder the success of your implementation. Okay, so kind of knowing that these traditional pieces of the program evaluation logic model have sort of one-to-one correspondence with implementation concepts, it was not a huge stretch to actually develop an implementation-specific logic model. Okay, so everyone always says, JD, you created this, of course you're going to endorse using it. Well, obviously. I may surprise you, I don't use this in every one of my grants. I don't use this on every single project. I probably should, honestly. And you'll see why. Some of the research that we've actually found shows the reasons why you should use the implementation research logic model. But we also have a couple of kind of ringing endorsements, I guess, or just carrots and sticks, I guess, about why you should learn how to use the implementation research logic model. So it has been required by name and by citation in FOAs from the NIH, AHRQ, and CDC. So not saying you need a logic model, you can use the IRLM if you want, but saying you need to use the IRLM. And they have actually, at least NIH, has sent back applications saying they were non-responsive when they did not use the IRLM. Boy, what a waste of time, huh? The other thing that I just want to mention that it is the second most cited article in the journal Implementation Science since 2019. And I actually looked today, it is actually now #1. No big deal. But yeah, nice work, right? No, and part of it probably is actually that some of these FOAs have required it. So people have published it in their study protocol papers. They've published it in as a figure actually in their pilot study findings because it was part of their grant. So it really was a model that they used to inform the work that they did. So I'm sure that actually did have something to do with why it's been cited as much as it has. But regardless, if you don't trust me, trust the numbers, I guess. That's what I'm saying. Okay, so the structure of the IRLM. So because most of us are familiar or at least have seen the program evaluation logic model, we began with a similar looking model. Okay, we wanted to use a pipeline format. There are other logic model formats that are more cyclical, a little bit more dynamic, that arguably probably can capture some of the phenomenon in implementation research better than a pipeline model. But because this is familiar both to funders and to most of us as researchers, we wanted something that looked kind of familiar. Okay, you already seen that. Yeah, I just said that. Okay, so theories and elements of the IRLM. So there's an underlying theory of implementation research, which we call the generalized theory of implementation research, that underlies the structure and sort of the connections in the IRLM. Okay, this is not my theory. We borrowed this from multiple folks who have written about this kind of generalized theory. We called it generalized because we pulled together multiple sources about how people have talked about what we are trying to do in implementation research. So here's some of the key assumptions. So we assume that implementation strategies are selected for a given evidence-based intervention, and they are related to implementation determinants. So I'm going to pick implementation strategies that align with the needs or requirements of an evidence-based program, and that help me overcome barriers in my context or leverage facilitators in that context. And this goes back to I think Danny's point about, sort of these crapshoot things. The same thing is true in implementation strategies, or at least has been. I can't remember who said it. I always see it in Byron Powell's slides, but there's a saying called Isgalagat, which was the rationale of why'd you pick your strategies? And someone says, oh, well, it seemed like a good idea at the time. Okay. Yeah, we want to get away from that. So there really is more of a push towards picking strategies that are clearly aligned with the EBP and with the implementation context. We then make the assumption too that implementation strategies work through specific mechanisms of action to change the context, so change the barrier that you're trying to address, or the behavior of those people in the system to help achieve the outcome. Okay, so mechanisms. And then finally, we think that implementation outcomes are the direct proximal impacts of the implementation strategy and the outcomes that it works through, which then relate to the distal innovation, recipient, or user outcomes, which you can just call health outcomes. Okay. So the IRLM is supposed to help aid in the specification of the relationship between these four things, which we consider kind of foundational elements of implementation research. So really, we're trying to actually come up with a whole bunch of these determinant, strategy, mechanism, outcome, causal paths. Sometimes I call them causal paths. They're not always causal paths, but they're essentially linkages between these four things that should be present at any time you're doing implementation projects. So some of the definitions of the different elements, we've already heard a little bit about this, but I want to put formal definitions on these. So determinants are factors that prevent or enable improvements, okay? You can put a valence on them and call them barriers or facilitators, but you can say implementation climate, for example, is the determinant. If you have a good implementation climate, it's a facilitator. If it's a bad implementation climate, there's a barrier. These things can act as modifiers, effect modifiers or moderators of the relationship between strategies and the outcomes they achieve. They can potentially be the mediator in that causal path, indicating that they are a link in the causal chain. We have implementation strategies. We've heard about that already. Mechanisms of action are the processes or events through which strategies operate to affect the desired implementation outcome. So you have to be really specific about this. This was also a problem in implementation research, probably about 10, 15 years ago, where people were like, well, I just want to improve implementation. Not getting into the specifics about this strategy actually was intended to improve reach. This strategy was intended to improve adoption. This one for sustainability, really breaking down why the heck are you doing what you're doing. And then our outcomes, obviously we've already shown a little bit of the distinction between implementation outcomes and clinical outcomes, but I'll come back to those in a few ways. So there's a number of different formats that the implementation research logic model takes. I'm actually only going to show two today in my brief piece here, but then I have a couple of examples that show additional formatting considerations. I mostly actually show these slides and the examples to show you that you can take the logic model and make it your own, make it fit your project. It is not prescriptive, and I'll even talk about this in a second. We do not use rules about how to create it. We use principles. So follow these principles, but that means you're not all going to end up with the same thing, and that's fine. So here's what the IRLM looked like initially. This was what we put it forward as the primary implementation research logic model. So on our left side pipeline, we have our context, just like our normal one. So we have our determinants. If you've ever used CIFAR, you probably recognize these 5 domains of the original CIFAR model. We then have our implementation strategies that, again, should be conceptually, theoretically, or empirically linked to the barriers that they're trying to address. We have the mechanisms through which those strategies actually operate. And then we have our outcomes. And outcomes in the logic model are not limited to implementation outcomes. And you'll see in the next slide kind of how it's more explicit about how these things operate. But essentially, this far right-hand box is actually Enola Proctor's implementation outcomes framework turned on its side. So the idea really is that implementation outcomes are the first thing that you'll see effects of the strategies on. These operate through improvements in service outcomes, which is just the IOM standards of care from 2006, timeliness, equity, effectiveness. And then you see clinical patient level outcomes. So you see improvements in functioning, reduction of symptoms, fewer diagnoses, prevention of infections, all those kind of things. What we ended up actually learning after doing this work with, 110 projects, I think, in the first 2 years of the Ending the HIV Epidemic, which is one of the NIH RFAs that required the logic model. We used it actually as our primary source for consultation with the project. So we said, if anybody asks for consultation, the first thing we said is send us your logic model, wherever it's at. We learned that there was actually an additional piece that was really critically important for a lot of projects. And that is the intervention, okay? It seems kind of obvious that I can just describe my intervention over here, somewhere else in my grant. But the innovation, again, kind of going back to the connection between strategies being related to context. Your strategies also have to be related to the intervention, which we see with this little upward blue arrow. And in many situations, when there's more than one intervention that you could choose, you're picking an intervention that aligns with your context. So think about all the different ways you could address depression. Man, there's a bunch of different intervention options there. I'm going to pick one that's actually aligned with the capacity, the resources, the barriers, facilitators, and other contextual factors in the place that I want to implement, right? So the thing that really actually clicked this for us on this one is that a number of these 1 and 2 year pilot grants They didn't actually have an intervention. They had outcomes that they wanted to achieve. They had a place they wanted to implement some HIV prevention or treatment intervention. But their pilot was actually to figure out what's the best intervention for this problem and this setting. So having it actually explicitly in the logic model was really helpful for folks. The other format that I won't show, which has also come up a couple of times, is people often, this is one of the common mistakes that we see with the logic model, people will put intervention mechanisms in the strategy mechanisms box. Okay, wrong level. So we also have a version that has innovation mechanisms too. And that really just helps people when you say, like, someone says, like, oh, here's one of my mechanisms. You say, is that a mechanism of the intervention that's going to change patient outcomes, or is that a mechanism of one of your strategies? If you have both boxes, just helps people put it in the right place. So examples of things that we've done to modify and adapt the logic model, but there's tons of examples of people doing things that I never would have thought of and were very effective for their particular project. The other thing I want to point out here is the little grayed out or like slightly less, I don't know, I use transparency, whatever that is in PowerPoint. That is intentional, okay? So effectiveness research basically looks at just those two things. It looks at whether the intervention works to change outcomes. So that is the direct effect of the intervention. The overall effect or success of the implementation incorporates everything else. And Amy's very quick little thing on the bottom that she didn't do a lot of, full scale explanation of the 50% uptake of every implementation outcome achieves your overall population benefit, that requires all this stuff working, okay? If I have a huge intervention effect, but I only reach 10% of my population, wonderful. You're going to get into an effectiveness journal, but you're not going to have a high population impact, okay? So that's why we focus a lot on the other pieces of the puzzle too. Any questions about the format or structure of the logic model before I move on? We need to get you a microphone. Elisa's going to ask a question that's probably going to be very difficult.
Thanks, JD. This is actually really simple. The arrow pointing from the innovation to the strategies. Why isn't it the other way around?
So that's, I think I've had people ask a similar question. You could probably do bidirectional arrows on the majority of these, especially the determinant to strategy and strategy to innovation. But really, in most situations, at least when you're thinking about picking strategies, the things you have in place are going to be, I know the context, I know my intervention, I know my outcomes. So when that's the case, you're looking for kind of convergence about what strategies are going to help me achieve that, given my context and intervention. You could think about it the other way, though, for sure. But, so I think, are you asking that because typically strategies support the intervention? Yeah, fair. That's totally fair. Maybe I should change that to a double-sided arrow. Danny has a comment.
I thought it was an interesting question because maybe, you tell me if this is right, maybe what you meant with innovation is what is the innovation, but use of the innovation is over there. It's in the outcomes. You know what I'm saying? So yeah. There's two places where the innovation gets talked about. One is just what is the thing, and then over there in the top right, it's probably using the thing or adopting. Am I right about that?
Yeah, absolutely. So that is how much and how well people do the thing, of course, on the outcome side. What's intended to be sort of in the innovation box is all of the actual components and characteristics of interventions that are important to consider. So, I work with a lot of like multi-component behavioral interventions. Oftentimes they involve multiple staff. They involve multiple data systems. Actually putting that into your innovation box will help you say, okay, I need an EHR that can do these kinds of functions. What, in my setting, does that exist? Or am I going to have to help create that? Do I need resources and capacity building to actually create the necessary situation for my intervention to even be implemented? Okay, so that's what the innovation box was really intended to do, is break down exactly what you need. What kinds of staff do you need? What kinds of workflows? What kinds of new technologies would actually need to be implemented as well to make this work? Okay, more questions later. So using the IRLM, so you can use it for kind of 4 major purposes. Most commonly, people have used it for planning. right? So what we recommend here is like this, the planning can really happen in kind of multiple stages, of course. If you're going to use the logic model to either in a grant itself or just to help you organize your grant proposal, that can start way before the funding even starts, right? As soon as you start to actually think about, let's do an implementation project, we do talk about really incorporating either feedback from or actually co-creating the logic model with community partners and or organizational stakeholders, in part for two, there's actually three major reasons. One is they know the context better than you do. Okay, so they can help you really say which of these barriers are that you've identified in the context are most important. The other thing is they can really help you pick implementation strategies. Okay, I've had multiple situations where we've had a project getting started, and I've gone to the literature and said, okay, here's the strategies that people have said are really effective for guideline implementation. And I'll go back to my partners. I will have put those in the logic model, and I'll say, what do you guys think? And they'll be like, it sounds nice, but we tried that, didn't work. Okay, well, when did you do it? What happened, et cetera? Bottom line was they're like, we're not doing that again. It didn't work for us. Do not propose that. That's good to know. That's really good to know. The other thing is that this helps you demonstrate either implicit or explicit buy-in with your plan. Whatever you're proposing and you're putting forward, my community partners have signed off on what I'm proposing, which I think gives you a little bit more credibility than just having a letter of support that says, yeah, we love this project. If you actually engaged the community partners in completing this over a multi-month period and they had input on exactly what's in it, that's really good evidence of buy-in. And we have now 2 papers that actually have a published methodology, step by step, for how you actually do this with community partners. Happy to share that with anybody who'd like those references. Actually, the Knapp et al. Paper, I think, was in the reading, right? Did I send that? Oh, we don't remember. Okay, we will send that. That's the Knapp et al. Paper right there. And actually the last one, or actually, yeah, never mind. Never mind. These are all examples of papers that I was on. So, okay, executing. So this is actually when you have an implementation project going forward, right? When you're actually getting into the implementation process, you've funded grant, you're going. The IRLM can really serve as sort of a one-page protocol and a means of tracking what you're actually doing. Okay, so you see all your strategies there. You see the outcomes you're trying to achieve. You know, you can really use this as sort of like one page, here's what we're doing. People have also used it to report their study findings, which really can be a helpful figure to you know, just really supplement all the rest of the text and give people a snapshot of what you did and what you found. It's also been used for synthesis. So when I wrote this in the paper, this was a little bit pie in the sky. I was like, I don't really know if it's going to work that well for this. But it did not take very long for a couple of papers to get published that actually used the IRLM to synthesize implementation projects that had done similar implementations in similar contexts with similar EBPs and said, hey, here's the prominent barriers that people found, here's the strategies people found that worked, and here's the outcomes that people actually achieved. Okay, so this was like in one of these that's cited here was a systematic review. One was a multiple case study example that was prospective. So they had 3 or 4 sites, all did the same thing, different protocols, or at least didn't have like a really, you know, strict protocol adherence requirement. And then they combined all of the findings and say, hey, here's a generalizable logic model for this particular problem. Okay, so how do you actually populate and use the IRLM? So I use the word populate as basically like, how do you get all the components in there, right? So again, instead of using a rule-governed approach or like you have to do it this way, we just have principles. Okay, so there's lots of different ways that people can do this and have done it, but really kind of try to follow the principles. And they are sort of in order of importance. Maybe principle 1 and principle 2 are like 1A, 1B in reality, but the first 2 are the most important for sure. So the first thing is to strive for comprehensiveness, and this really goes back to the whole thing about reproducibility and transparency that we were trying to address. So in your determinants, include all relevant determinants, not simply those that you think are the most important or the ones that are going to be hypothesized to be related to strategies and outcomes. Okay, because other pieces in the environment that you're working in, you may or may not anticipate that they have an effect, but they do. And if you ignore things that are potentially facilitators, and someone doesn't know that and tries to replicate, and their context doesn't have those same facilitators, but they had no idea they were important, they're not going to probably be able to replicate the same way. The valence should be noted. So we saw a few examples in piloting this that people just said, capacity. That was what they put in over here on the logic model. We're like, okay, well, what does that mean? Do they have good capacity? Do they have bad capacity? They have, like, be more specific, okay? So at least indicate valence. Is this a barrier or facilitator? You can add just plus or minuses to indicate barriers, facilitators. I personally really like Laura Damschroeder's 2013 way of doing it, which is a multivalent scale from -2 to +2 that gives you degrees of how much of a facilitator or barrier a particular thing is. And 0 basically means this is probably going to have a neutral or no influence, or if you're multiple sites, it's highly variable. And so we can't put like, it's always a barrier on it. We also recommend people not use like study specific adjectives or change the name of determinants, like saying greater relative priority, because greater to what? Like, what does that mean, right? It makes sense in your study for you, but it doesn't make sense for somebody else trying to pick this up and trying to understand what you did. In implementation strategies, list all your strategies. We see this in protocol papers still, that someone's like, I'm really interested in, training. Yet they did like 9 other things. Okay, training was the main thing. That was the thing they thought was going to be really the most effective. Maybe it was the most innovative thing, but there's a lot of other strategies that actually happened, and make sure you list all of them. And in some situations, I don't have that on here, list strategies that are in place in the system, even if you're not going to utilize them. So if you go into a hospital and you're going to implement a new thing, and they have a quality team, they have a team that does PDSA cycles routinely, and they're going to apply it to your project, but that wasn't really what you were interested in, you better put that, because that's probably going to be helpful. You can also indicate the strategies in certain ways. So was it in place in the system prior to the study, and we're just leveraging it? PDSA cycles, quality, good examples of that. Or were these things that were initiated prospectively for the purposes of the study, which is really important for experimental designs. If it is a strategy you are introducing and it's going to differentiate arms or be part of an actual test, that's really critical to indicate that. When you're actually using the IRLM for reporting the outcomes of a study, don't just list the things that you think were effective. List the things that you tried that didn't work, okay? That's as important in many situations of like, yeah, we tried to do passive facilitation. It bombed, okay? Don't try that again. The other thing is, it's very common to introduce implementation strategies or to modify implementation strategies during the course of a trial. Okay, in certain situations, that's not good. It could be a protocol violation or a protocol deviation. But in other situations, it's just gonna happen. And so actually reporting that and saying, yes, this was not present at the beginning. Here's the reason it was introduced, can be really, really important for that reproducibility and transparency. Most of these things are really relevant to the IRLM used during planning, but during ongoing tracking, you can also use this to show how strategies have changed over time. I think the article in process is now submitted, so maybe it's going to be out fairly soon. And for retrospective applications, so if you have an implementation project and you want to apply this post hoc to show here's what we found, you can definitely do that. Just make sure that it's as comprehensive as you can get, even if you didn't track things all the way through. The last thing for outcomes, this one's simple. Just list all the outcomes that are important, okay? So people do get into like the thing of like, oh, I'm using re-aim, I have to use all the outcomes. You actually don't. Like you could actually just only look at adoption and reach if that's the clinical or implementation gap that is really trying to be addressed. But you should list the other outcomes too that are relevant, especially ones that you're measuring, okay? Here's the one that people forget to do the most. And unfortunately, it's one of the most important pieces and contributions of the IRLM, is to indicate the conceptual relationships. So we often see people just throwing everything in the box and being like, good, I'm done, I completed it. Not good enough, sorry. So you need to indicate the relationships between the elements, and this often aligns with the specific theory of change for the study. So you can use established theories of change if you have a strategy that's trying to improve clinician acceptability, skill, et cetera. You may use COMBI or something like that because you're focusing on individual level behavior change. If you're trying to change organizational behavior, there's a number of organizational behavior change theories that you could apply there. So multiple theories potentially for multiple levels. but essentially providing some indication, and I'll show examples of this in a minute. My favorite is actually using superscripting because it gets very busy, and using colors, using arrows, with the exception of in presentations that you can use animations and take away and bring back things, is really difficult. So I really prefer using superscripts and limited color coding. Okay, yeah, the last part's super straightforward. Okay, so if you would like to incorporate study design elements into your logic model, it is possible. So indicating the primary outcome, easy, bold it, put a asterisk next to it, and put a note that says, this is my primary outcome. Okay, if you're doing an experimental trial, and maybe it's an efficacy trial of an implementation strategy, and you say this strategy is for reach is your primary outcome. You might be measuring adoption, sustainment, et cetera, but you need to indicate what your primary outcome is. And this might actually be at multiple levels depending on your study design. One thing I do want to point out is the levels should align with the specific aims and the level targeted by the implementation strategy. I still see this issue a lot as a reviewer, both of papers and grants, is that someone's ultimate primary outcome is actually at a different level than the implementation strategy, which just doesn't make a lot of sense in most situations. I know Danny's like giving me that's the face I put on when I see these grant proposals. I'm like, are you serious? Yeah. So my suggestion too is to also include the downstream health services and clinical outcomes, even if you're not measuring them. You may say, why would I not measure these? In a lot of pilot studies, we might only get to the implementation outcome and say, hey, that's good enough for our pilot purposes. Or there are situations too where kind of what we would call a pure implementation trial happens, where you can't actually get clinical outcome data. Kind of rare circumstances these days, but it does still happen. So here's some other things too. I'm gonna send this out so you can look at this, but there's some examples that I'll show. Oh, additional specifications. So there's a number of other things you could potentially do for your study. You could notate elements that have been or will be measured versus those that are based on your experience, prior studies, or inferred. But my bottom line is just be creative. Whatever's going to help. This is like creating any figure that you would have for a manuscript or a grant. Do whatever is going to supplement and improve the text, and obviously replace that text because you want to make this as maximally communicative as possible. Okay, so here's some examples. These are all, I think all the ones I have right here are ones that I was involved in, so they don't show the level of creativity of other implementation researchers. But so in this project, again, we broke down all of the individual components and characteristics and things that are related to the delivery of the intervention. This tells us lots of different things about what's needed and how to align them with barriers. In this particular project, we started with outcomes. This is fairly common to say, here's what we want to achieve. This is what RE-AIM does when you use RE-AIM as a planning framework. You start with where do you want to go? We then actually filled in all of the determinants, so the context that we were working in, which was federally qualified health centers in the Deep South. We then completed all of our implementation strategies and hypothesized the primary mechanisms through which those would work. And the thing I really want to point out is all of the superscripts, okay? So the way that we do the superscripting is once you get all of your strategies down, label them A, B, C, D for all of the discrete implementation strategies. The next step, typically what I would do is I would say, now why did we pick that strategy? And I go back to the left. What barriers and facilitators is this particular strategy associated with? And you should be able to pick at least one. Otherwise, why are you doing that strategy? Okay. And this also is a good test of the comprehensiveness. You may have a good reason for doing that strategy, but you forgot to put that barrier in. Okay, so this helps you fully flesh out the entire logic model. We then move forward in the causal path, and often because implementation strategy mechanisms are kind of the hardest thing for people to think about, I find it really helpful to first actually do what is the outcome that this strategy is supposed to be helping me achieve. It could be two, because implementation outcomes are often sort of interrelated, but you should pick a primary. Like the direct effect of this strategy, I hope, is on adoption. It may also help a little bit with reach, but it's really meant to at least first achieve adoption. And then from that, I can actually go through the little mental exercise of saying, okay, if my strategy is trying to address these barriers and achieve this outcome, what's the mechanism that's going to help that happen? So the mechanisms are almost always the last thing that you fill out because you need that additional information. Your mechanism is often actually the modification or changing of an implementation contextual barrier. Okay, so having all those pieces can really help you actually do the mechanism part too. What else is important about this one? You see the multivalent coding over here on the left. So we have our -2 to +2s that we did in coordination with people from the sites we were working with. And we indicated our primary outcomes. The primary outcomes, there's multiple, which goes in the face of primary outcomes. It's because this project was in 2 phases. We had a pilot that was looking at acceptability and feasibility of the implementation strategy we were using. And then our actual trial is adoption. That's our primary outcome. So that's not indicated in the logic model. We could have done a better job with that, but this is why you need accompanying text. You can't just throw this up here and expect everyone to understand exactly what you did. But heck, I can make a lot of sense out of this without knowing anything else about the project, okay? So that's one of the things that's really useful about the logic model. Okay, let me go to the next one. And my animations are garbage in many situations. Here's a good example of my terrible animations. Let me just fill everything in for you. I can't remember what I was trying to do with these things, but either way, it doesn't matter. So this is another one that has the same kinds of things. We did the superscripting for all of our causal paths. We did the positive-negative valence coding. The thing that's unique about this one is in the implementation strategies box, can anybody guess what kind of a research design we had for this? I'm kind of looking at Danny here, but anybody else want to take a guess? Okay, it could be a 5-arm trial because I have 5 primary strategies. This is actually a factorial. It's a full factorial design. So we had 5 strategies that were going to be all of our factors. We had a set of core implementation strategies that every condition had to get because they're required. They're essential. I have to train people. Doesn't matter what strategy condition you're in. If I don't train you, you don't know how to do it. It's not going to work. Okay. So we had a set of core strategies, 5 factors. Instead of showing like an actual factorial grid, which you could do, we had just 5 strategies. Okay. And it's in the legend, I think, too. Yes. Yep, full factorial. Yep. So that's the unique thing about that. This is the Circle Chicago project, which is an implementation research center as part of the Decipher Alliance. The thing that's unique about this is the first example where we actually depicted a multi-level intervention trying to be implemented. So anybody do research on multi-level interventions? Okay. So by definition, multi-level interventions include interventions at multiple levels. Boy, that was a duh. Nice job, JD. But what's important is in the logic model, that means that you have a package or you have a bundle of things you have to do. And in this case, which is similar to most multi-level interventions, we have our clinical or health components of our multi-level intervention that are patient-facing things, like medication in this one. And we have implementation strategies. So I can't just put that whole thing in the innovation box in the same way that I do a pure clinical intervention like I had in the previous examples. This thing has to be implemented as a package. This is the Kaiser Hypertension Control Bundle. It was tested as a package. It was replicated as a package. So if we're going to do it the right way and follow what they did, we have to do all these pieces. So this is just a way of showing this is the implementation strategies and intervention components that are part of the bundle. And then we have a set of implementation strategies above that are helping us implement the whole bundle. Okay. Again, none of this stuff is like rocket science, I don't think, but this is just really helpful to actually look at exactly what we are doing and how we're going to do it. And you can see here that's a little bit unique too, is that we included all of the different implementation strategies within the bundle in our causal path coding, okay? So the way that the bundle works is also incorporated into our logic model. It's not just about the strategies that we use. The last piece I'll point out with this is another situation where we had core strategies across a 2-arm parallel cluster randomized trial where our independent variable was practice facilitation. So we're testing the effect of how much does practice facilitation improve the implementation above and beyond a set of core strategies for the implementation of the Kaiser bundle. So That's where that little practice facilitation in one arm is indicated there. Okay. Oh, here's one for hypertension guideline in kids. The thing that's cool about this is this was actually done as part of a 1-year pilot grant in preparation for an R01. So we did, this is the NAP paper that I mentioned earlier that I can send around, which was really this methodology for how do you engage stakeholders meaningfully in the selection of implementation strategies that you'd propose for a trial. So this is what we accomplished. If we didn't do more than that, we didn't actually get to outcomes in this. This is what was actually included though in the grant proposal. We had the full logic model, everything we were trying to achieve, but we were very clear that the results of the pilot was just the left-hand side, was our full contextual evaluation, and then all the candidate implementation strategies that were selected in partnership with our clinicians and system leadership about what were they willing to do and did they think it was going to work, okay? One more example just to show you a multi-component intervention. So 2 different components of the intervention. We organized this one actually according to levels in our barriers and facilitators rather than using CFR or some other framework. We just said, here's the levels and the barriers that exist within that. And then obviously here's all of our strategies, mechanisms, outcomes, and how do they relate to each of the different components. So we use different strategies for doing screening versus strategies for doing the actual behavioral intervention, okay? This is a project that is gonna get funded, it looks like. So this was exactly what we put in our grant proposal. So really quickly, I'll talk about the acceptability and usability. So we did a 2-day in-person training for grantees that were funded under the National Ending the HIV Epidemic back in 2019. We did an administration of a survey to 132 participants, 129 completed the pre-training. 6 weeks later, we had 66 of those folks complete the follow-up essentially. There was 10 items. So here's the things I really want to point out. Here's the things that people said were really the most important about using the IRLM is that they thought it improved the rigor and reproducibility of their study. They said they thought it would serve as a roadmap for actually executing their project. These were all grantees, so they had projects funded. They thought it was going to clearly help them to clearly report and specify their project plan. It helped them understand the connections between determinant strategies, mechanisms, outcomes, and it helped them actually identify gaps in the logic of their project. I have heard that every single time, that even after getting a project funded, dang it, I wrote a darn good grant, I got a 15, almost a perfect score, and yet I do the logic model and I had things that I didn't actually put in there that I hadn't thought of. So it's actually a really helpful thing. And if you look at the rest of them, every one of them's over 50% was moderately or very helpful in even these other pieces. Okay. I'm going to skip this, but here's the NAP paper looking at all the steps that we went through. But this is kind of a lot to actually talk through right now. So this is, I'll send this out to everybody, as well as a version of this, which I think I have in here too. Yes, I do. I already showed our logic model. I have a version of this that's actually shorter. So we had a sort of 12 hours of engagement with our clinician partners versus a 6-hour of engagement here where we were able to accomplish the exact same thing. So a much more in-depth, longer version for more complex things like guideline implementation, which is multiple component, involves multiple implementers, versus this project, which involved far fewer number or type of implementers and a slightly more simple evidence-based intervention that needed to be implemented. So 2 different papers, both are now available. There's a bunch of resources available for using the IRLM, and I just got another grant to actually update these and make them more contemporary and more useful. But we have a quick reference guide that gives you a lot of definitions and examples of things that go into each box of the logic model that's really nice to just have next to you as you're working on it. We also have worksheets that go into tons of detail about each one of the things, with the exception of mechanisms. Back in 2020, 2019, whenever the heck we actually wrote this paper, there was so little guidance on how to determine, define, identify mechanisms that we just left it out. And the reviewers didn't tell us you had to put one in. So there isn't one, but that is actually one of the main pieces of this new grant is to develop guidance for how to actually do mechanisms within the logic model. Did I stay on time? Am I good? All right. That's my thank you. We have time for questions. Okay. Questions, derisive comments, suggestions to improve this darn thing? question in the back. Oh, back and front. Oh, yeah. Hold on.
So when you used the, when you were scoring the determinants, was that the research team doing that?
It depends on the study.
Okay.
So most of the ones that I'm showing here, no.
So that's from prior literature? Or?
So it's from multiple sources.
Okay.
So in some situations, prior literature is totally fine. There is enough literature to say it is difficult to do X in primary care. And here's the reasons why. So I can just pull that and say, you know, dozens of studies have shown that funding, workflow challenges, and IT are going to be barriers. I can just go with it. In other studies where there isn't quite as definitive or just clear evidence that these are the primary things you need to focus on, we would do primary data collection as part of our pilot. So either, you know, almost always a mix of validated scales and qualitative interviewing or focus groups, because there's a lot of those determinant variables that don't have validated scales. So we typically use a mixed methods approach. And so if it's a validated scale, we will actually use the norms or use the average score and mean and standard deviation to figure out what the valence is. If it's from qualitative coding, we actually follow Dan Schroeder's approach. So she, in that paper, actually talks about qualitative coding and how to apply the -1, -2. And in every situation, we brought the findings back to our clinical partners and implementation partners and said, does this jive? Is this how you see things?
Thank you.
Yeah, good question. I just totally blew over that part. I see lots of like gingerly hands going up. Like,
thank you. I was just wondering, sort of practically, it sounds like you submit these very comprehensive figures in grants, and it works, and the reviewers get it. And I've also, I guess, heard in talks or read in papers, like with the CFR, don't use every single determinant, just choose the ones that you think are important or that evidence shows are important. So can you just kind of clarify in that case, like, do you include everything just to say, like, and we don't think it's important, but we've sort of checked the box, or
so two thoughts about that. So often what they talk about with CFR of not using everything is a pure practicality. You can't measure all of them in most studies. It's overwhelming to actually go through 60 plus, and now it's over 70 variables within the new CFR, the updated CFR. So you're right. They have said you're not expected to do a comprehensive evaluation. In a logic model, though, it's easier. Not all of these things are measured. They're not going to necessarily be measured. So it is easier to be comprehensive. That's my first comment. My second comment is I put in the comprehensive model, and I do a really good job of explaining what the logic model is and giving a little bit of explanation about what it's showing. I have also done simplified versions where I really focus on the primary barriers and facilitators, the primary implementation strategies, and I'll limit the number of outcomes and mechanisms for brevity, but also just total clarity, not to get overwhelmed reviewers. You have to just say that this is not comprehensive. And I usually will put that in multiple places. I will say that this is only picking the primary or most important variables in each one of the boxes to capture the essence of the study. I will put it in the figure caption. Otherwise, you'll have a reviewer who expects that looking thing, and they'll ding you for it. Like any figure, though, I have reviewed a ton of grants that have had logic models, and if you don't explain it well, and you don't include some of these causal, sort of paths and other things, it's not a helpful figure. So just like anything, if you do it well, it can be really helpful. If you don't, it's going to not help your case, or in some cases, it'll hurt you. But happy to share examples of how we've done it effectively, if you'd like to see those. Less than half. It's about 2/5 of a page. So you can use 8.5 Arial narrow. I'm not kidding. That is legitimately the smallest that you're supposed to use within a table or figure for NIH grants. So, and use exact line spacing too. Yeah, exact 9 with 8.5 works great. Yeah.
I think sort of as I'm looking at the logic model, it seems to me that what you're doing with implementation strategies is really similar to the implementation strategy mapping.
Yeah.
Okay.
It is. So I'll say 2 things about that. So this is in comparison to causal path diagramming or implementation mapping, this is a simplified version. So you can, and I've been a part of a grant and I've seen a grant that has done this, that has actually done implementation mapping on top of the logic model or as a supplemental activity. Really, the point is, and I've talked to Maria Fernandez about this actually at length a couple of times, it's not necessary to go through implementation mapping for every strategy in most studies. It's really the primary ones, the ones that are being tested, the ones that are novel, that you need to potentially go through that process. So that's where you would do that as a supplemental piece and just focus on the ones that are important. Similarly, for like causal path diagramming, that's Carol Lewis's approach and the mechanisms group. We had similar conversation, and she agreed. That there is value potentially in going through causal path diagramming for every strategy, but it's really the ones that are most important and potentially the ones where you're going to test the mechanism. Because if you're going to test the mechanism, you need to be right on so that you measure the right thing. But a little bit less important if it's just, I don't know what strategy, like leadership engagement, and there was only one meeting. Like, I don't know, what's the value of measuring a mechanism there?
The other question I have, it relates to this understanding importance. It encourages one to think of all the implementation strategies that could be done, which could add some sort of incremental marginal benefit.
Yeah.
But at the end of the day, how do you utilize this to choose? Here's sort of what I feel are the most cost-effective early implementation strategies that I would want to introduce.
Good question. So that's actually the process that we described in this paper that I'll share. And you can see the color coding of the strategies. This was actually, we did an extra step that I didn't talk about, which was once we actually had our whole list of candidate strategies, we had everybody on our panel, which in this case I think was 9 people, do a very simple Likert type rating of every single strategy for how likely is this to be effective at overcoming the barriers that we've already linked it to. How likely is it feasible for your system to do this? And we asked a third question that was, so those first 2 were informed by the ERIC compilations Delphi approach. The third question that we added was, what should be the priority level of this strategy? And that helped us tier the strategies. So in this particular project, our research design is actually only to implement, at least in the first cluster, the package of the green strategies, because those were the ones that were all deemed highly feasible, likely to be highly effective, and high priority. The orange and red are less feasible, less likely to be effective, lower priority, all those different things. This particular design is an optimization design. So what's cool about the way the logic model works in this particular case is all of these strategies relate to specific mechanisms and outcomes. In our first cluster, if one of these strategies does not work, or if we do not have the effect on an outcome that we want, the logic model has already told us, here's another strategy that is likely to be affecting the same outcome, potentially through the same or a different mechanism, that I can like plug and play. And it could be that I'm pulling out an ineffective strategy because it's infeasible, didn't work, definitively garbage. Or it could be like, hey, we don't have the effect we want. Let's add another strategy to supplement and try to improve the outcome. So the logic model, you've already done all the work to justify, and it's really easy to just go, let's go to one of the yellow ones, the yellow-orange ones, and just pick the one that plugs in, rather than having no idea what you're going to do. But that works in optimization and adaptive designs. Doesn't work, of course, when you're doing a more of a static type implementation strategy. But that has been something that's been really helpful for us, is to really think through all these different kind of combinations and possibilities so that you can pick and choose in a way that's really driven by theory and by a good, strong rationale. 2 questions. Okay, you're first, second.
hopefully a quick question. Thanks for a great presentation. You earlier alluded to, things like black boxes, like saying capacity with sort of broad strokes. You mentioned you use like the Damschroeder 2013 paper. Do you use any other sort of readiness for change models or any other things that you can kind of summarize that idea of organizational capacity, or what else might you recommend there?
Yeah, so I mean, this kind of goes into a slide that I dropped for time, is that you could have supplemental text, figures, and tables for every single one of these things. And we often do actually have, supplemental tables that go into how we measured, what our actual findings were for all of the contextual determinants. But to your point, incorporation of like other frameworks, models, measurement approaches, processes for figuring out capacity and things like that would just be incorporated into the research strategy elsewhere. You can potentially include those kind of things in the logic model. I don't know if it requires a different box, or potentially a lot of those things are strategies. So actually going through the process of assessing for capacity, that is actually a strategy in the error compilation itself. So you could plug it right in there. Or it could be a whole separate process that you go through in your project that would be in your procedures.
So you mentioned that the team did a Likert scale, a Likert test to see which one were the most viable.
Yeah.
So in that, do you just put in red the strategies that are least likely, or do you just leave off strategies that you think are not viable? Because
yes,
I could be wrong, but is that more of an arbitrary? We get 9 people saying, yeah, this will work, this doesn't work. Is there some other kind of information that's being used to measure the green versus yellow versus red?
So in the process of planning, not really. There was 2 steps that I didn't mention because I didn't go into the full protocol for this, which is described here. But once we actually have the complete logic model, before we even do the coding, we actually go through a process of pruning. So we will say, are there things that we have brainstormed, the things that we came up with that are just not possible or not viable? They're actually not even included here. These were all ones that had at least a minimum threshold that, hey, yeah, we could do it. But you can see like doing provider incentives. That's expensive. That was why it was low priority, because this was pretty infeasible for people to replicate because it's resource intensive. So we kind of basically already did that process of cutting out candidate strategies that just were not viable at all.
Hi, JD. Could you go back? I think it's one slide where you had the multifactorial design, that it was like a 2 to the 5th, I think.
The one with the factorial thing?
Yeah.
That. Yeah.
Okay, so I think it's this one, and it's not so much a question about the IRLM, but trying to tie it back to other concepts that we've heard throughout the morning. So first off, I was wondering if your framework works for any kind of hybrid design, or is this? So it seems here you're focusing more on the strategies themselves than on the effectiveness of the intervention, right?
Right. It's all there. I mean, there's an arrow missing here directly from intervention to intervention outcomes, but it's all incorporated.
Yeah. So what I was wondering is also some of the interventions, and probably not on this slide, but maybe in the preceding one. So is that a bundle and related to the question about what score, right? Because if you're telling me every time if I need to address this issue, I need to do these 7 things, do we have the evidence basis for all 7, or is that just the way the first person did it?
Yeah, I mean, in many situations, if you're talking about the intervention or the strategy?
About the intervention itself, like what's in the bottom.
So all of the interventions that are in the bottom are evidence-based interventions. None of these are like type 1s. None of these are in like the still trying to establish effectiveness stage. So these are replications of evidence-based protocolized interventions. So yes, everything in those boxes is what was done previously and what was probably replicated previously. So we're doing it again. Mm-hmm. Whether we have the evidence for that, good question. But in most situations, if you propose, I'm going to implement this evidence-based thing, and then you have a big long list of how you're changing that intervention, a lot of reviewers get really uncomfortable with that.
Yeah, it just seems to me like you could also benefit from doing the factorial kind of in the bottom too.
Oh, you easily could.
Because there's going to be overlap, right? And yes, it makes it more effective, but also are we just spinning our wheels?
No, that's a really good point. So that is, just like trying to layer on research design onto the logic model, a lot of times the logic model has no indication of research design. So I try to do it when it makes sense. And these are, every one that I've showed here is ones that I've been involved in. But a lot of them don't have any indication of what the research design is. And then you'll have a section of, here's how we're testing the intervention. So here's the control condition, here's the, if it's a factorial, if it's a multiple arm, whatever it is, and here's how we're testing our implementation strategy. So all that stuff can get layered onto. It's just a matter of how do you depict it, or do you depict it in the logic model. And you don't have to. Again, it's all up to you about what you think is going to help readers and reviewers understand your study, and frankly, what's going to save space, because you're trying to convey more in the picture than you do in the text. So usually, if I can portray it in the picture and just add on an element that I can explain on 1 or 2 sentences in my text, versus leave it out, but it takes 10 sentences to explain in the text, I'll pick to put it in the logic model. But yeah, you just have to figure out, like, for your particular study, what is the best way to do it. Yeah, good. Yeah, really good points.
I've been pondering this and thinking about the implementation strategies and how they relate to equity.
Yeah.
And one of the things I was thinking about is some of the things that that are taken for granted in high resource settings actually are a strategy that need to be tested but maybe seen as not viable to have an intervention be effective in a low resource setting, if that makes sense. So I'm wondering if you see that as depicted in the logic model, and how.
I can't remember if this is in my slides tomorrow. Do you remember if it's in my slides tomorrow? The whole thing about equity in the logic model? I think it is, right?
You can save it for tomorrow.
Okay, but I can even mention it though. So what we've been trying to do in health equity related projects, and I think I'm actually going to use this one I'm going to use my Circle Chicago one as an example. What we've been doing is really just indicating which of the barriers are things that are contributing to underlying health disparities. Okay, that's the first step. So which of the things that are happening in the context have led to demonstrated health disparities? Easy, right? Hopefully. We then, when you're going through the process of actually doing your strategy selection, you need to pick strategies that are going to overcome that barrier if one of your outcomes is trying to achieve health equity. And similarly, we notate on the outcomes, how are you going to know? Okay, so again, I don't remember if we're talking about this tomorrow or not, but reach is one of the easiest indicators, one of the easiest metrics. So it's not reach of saying like, okay, we got 80%, that means we got most of the people. I want to know who we got and who we didn't get. So who's in that 20% and who's in that 80%? So REAIM talks about that as what they call representativeness. But from a health equity perspective, it's basically like, who did we reach? Who actually got this and who didn't? Are we systematically leaving people out? And if you're leaving out the health disparity population that you're trying to address, you're probably perpetuating disparities. That's my very pessimistic thing, but I also wanted to freak people out. So yeah, so we do start indicating, here are the things that we think are the main causes of disparities. And then here's the ways that we're going to address it. And here's how we're going to know if it happened. But it's just, it's another extra layer, I guess, onto just doing a good implementation project, is really showing, hey, if we're trying to address equity, here's how it's happening. The other thing I will say is that I think there's been one paper written about sort of like the health equity considerations for CFR. We have a new model. Amy's not here. But as part of the Decipher Alliance, which is about disparities elimination, we have a new framework, which I know I don't need a new framework, but it actually pulls together health equity implementation framework, PRISM, which is REAIM's determinant framework, EPIS, which has determinants, and the updated CFR into one model, and explicitly points out all of the places that have shown to be demonstrated to contribute to the health disparities. So this new model is going to actually give you basically at least the left side of here's all the things that we think are contributing. Yeah, there's not very many models out there that actually do that. So it will make it easier. I think we have time for one more question, it sounds like.
One thing I was just going to say is that I think also from a policy standpoint, being able to really show that more implementation strategies may be needed to overcome barriers faced by low resource settings, and those have to be paid by someone.
So I will point out Jennifer here. Jennifer and I are both on the IMPACT Consortium, which is an NCI-funded PRO implementation and symptom self-management trials. We are doing comprehensive implementation strategy tracking. How many strategies did E2C2 use? You remember? 30? Okay. I think ours was 27 or 28. And every time I've shared that with, like, when I told Byron that, for example, he was like, no way. He's like, there's no way you did that many. But when you start actually looking at all the stuff that you do in a comprehensive and large-scale multi-component implementation, you're using a lot of strategies. Many of them are very minor, admittedly, but actually doing comprehensive tracking, and then by extension, comprehensive reporting, is really critical. So someone might just not know I have to do this little thing that every other site did, which is why they were, in part why they were successful. But yeah, potentially a lot of strategies actually get used. Okay, we're calling time. What's next?